if you're thinking about using a BTK inhibitor in a patient, I think it's just important to understand what their underlying risk for potential toxicity is. And so I think the first and foremost thing that a person should think about is the cardiac risk. And so I think there's not general agreement on what testing needs to be done. I think it's important to know what their cardiac history is, what their concomitant medications are, especially if any of them can interact with the BTK inhibitor and whether any adjustments need to be made. And then to think about maybe just some basic screening type tests, such as an EKG and then echocardiograph for those highest risk patients. Among patients who I think are high risk, I think it's of benefit to consult with a cardiologist to make sure that their cardiac status is optimized. And in patients who are extraordinarily high risk, then maybe I would consider using a different type of therapy instead, such as Venetoclax and obinutuzumab. I would say that comes off less often for me because our newer generation drugs, Acal and Xanu, certainly have a much improved cardiac safety than ibrutinib, but nonetheless, they're not without risk, as we still see maybe around a 5 to 6% incidence of atrial fibrillation with these drugs, which we would love to avoid, in addition to the risk of hypertension, which is perhaps a little higher with Xanu versus Acal, although we don't technically have head-to-head data on those agents.